And before we dive in, this is just a quick glimpse at what we're going to be doing today, the agenda. We're going to learn some general information on VWD and the clotting process. We're going to learn a little bit about getting a diagnosis and blood work, some precautions to take, finding a team, hearing a patient perspective, and you'll have the option to ask some questions. So now, officially at this time, I've been waiting and waiting, but I'd love to introduce our first speaker who has been fantastic throughout this entire planning process. And I just want to thank her for answering all my calls and emails. And she is currently a professor at Emerita and former director of Michigan State University Center for Bleeding and Clotting Disorders and former director of the Division of Blood Disorders, Centers for Disease Control and Prevention in Atlanta, Georgia. Ladies and gentlemen, my pleasure to welcome Dr. Rajni Kulkarni. Hi, Dr. Kulkarni.
Hello and welcome everybody, and thank you so much for attending this wherever you are in the world and in the United States. I wish we could see each other in person, but at least now we can listen to each other and see some of us. So really want to thank you from the bottom of my heart for coming to this session. So the next slide, I'm going to start off. So you know what the kids call me? My name is Roshni Kulkarni, but kids cannot pronounce Kulkarni, so they call me Dr. Cool Cat. So I am Dr. Cool Cat, and my purpose today is to make you understand what is von Willebrand's disease. You know, it's a kind of a mouthful name, just like my name. So I kind of feel like a connection to von Willebrand. I'll tell you who it is and where did the name come from. So to begin with, just wanted to know that blood, we all think of very precious fluid, a bottle of wine or this or that. But to be honest, for the body, blood is the most precious fluid in the body. And what it does, it flows in tubes called blood vessels. And its main purpose is to carry oxygen to the rest of the body. And without blood, well, you won't be alive. If you ever lose blood, like cuts and, you know, surgery or things like that, the body tries to make it up. So what is inside the blood? And you can see a picture of red cell. They are like little trucks that carry oxygen back and forth. You know, they were born with a nucleus or a central portion, but they sacrificed the nucleus so they could carry more oxygen. And then you also have tiny cells called platelets, which are like sticky jigsaw puzzle, and they kind of stick to each other and plug bleeding points. And then you have these white blood cells that are different kinds, and they're like soldiers in your body, and they prevent infections. And the next slide. I think the next slide will show you.
Can our tech person please click on the next slide, please? Thank you.
Oh, there he is. So this is what or who von Willebrand disease is named after, Dr. Erich von Willebrand. And this is perhaps the most common bleeding disorder. And the problem here is that the blood doesn't clot properly. And it was described by Dr. Erich von Willebrand in a large family. You can see there's a family tree. All the squares are men and all the circles are women. And all the ones who are like dark black have died. And the ones who are like light gray are the ones who are affected. So this was a family in a small island near Scandinavia called the Åland Island. And the case that brought this to his attention was a 14-year-old girl who bled to death during her 4th menstrual period. Now, you will never think of menstrual period as a cause of death, but that's what happened. And the next slide. I think the next slide will show you what is this von Willebrand protein. So it's a protein, and think of it as like a anchoring protein. So I'm going to be the von Willebrand protein, all right? So it's like a coiled sticky factor. So it's like coiled up. And when it expands, it attaches to a platelet. It's like a disc-shaped jigsaw platelet. And then it attaches to the blood vessel wall. So here is the thing, it's attaching to a platelet, attaching to the blood vessel wall, tethering it, so it's a tethering protein. And in its mouth, it carries factor VIII and protects it. So here we go. I hope you like that because this is one Willebrand factor. Well, when you don't have this little coiled up, little sticky factor, then the platelets don't stick and the von Willebrand factor doesn't stick to the blood vessel wall, and you end up having a bleeding because you cannot form a hemostatic plug. And the next slide will show you, I think the
Next slide, please.
So if you look at, there are all kinds of protein, clotting protein in the body or in the blood, and you can think of them as like a jigsaw puzzle and or a domino, and the last piece of domino falls on the broken blood vessel. So the next slide, if you can show me the next slide, we'll kind of go into what are the types of von Willebrand's disease. Well, so you can have very little amount of von Willebrand protein, which is called quantitative defect. It's less in quantity, or it can be abnormal protein. It's going to be different protein, which is called a qualitative defect. Normal levels, and they measure it in the lab, is about 50 to 200%. And the next slide shows there are different types of von Willebrand's disease. So type 1 is where the amount is less. So in many people, it's less than 30%. And they say you have bleeding problems, regardless of bleeding or not, you have definite type 1 von Willebrand's disease. Sometimes, as we said, normal is 50. Sometimes it can be between 50 and 30. So you can still have von Willebrand's disease if you're bleeding. And this is the most common type of von Willebrand's disease, type 1. The next slide shows the second type, which is type 2. Remember, I told you you can have little amount of it, or you can have an abnormal von Willebrand factor. Type 2 is where the protein is abnormal. So it is qualitative. And it's about 15 to 20% of cases. And I don't know, in the audience, there may be subtypes of type 2. So they are type 2A, B, M, and N. And believe me, even a lot of my residents and fellows cannot remember these types. So I've made a little mnemonic. A is absent, sticky part. So in the protein, one part is very sticky, that can be missing, or it can be bound to platelets and both are removed from circulation. So what happens is these patients have low levels of platelets. Type 2M, I put it down as mad at the platelets, doesn't stick to the platelets. So the platelets go about their merry way and the von Willebrand factor is there and they too don't interact and form a plug. And type 2N has nothing to do with factor VIII. Remember, I put it in my mouth that factor VIII, it protects. Well, when you have this particular type, it doesn't protect the factor VIII, and without the von Willebrand factor protection, factor VIII is destroyed. And many of these patients present with low levels of factor VIII. So it's a double jeopardy. So they have no sticky platelets. They have very low levels of von Willebrand factor and factor VIII. The next slide shows type 3. This is total deficiency. There's hardly anything in the blood. No, and this is the most severe type of von Willebrand's disease. Fortunately, these are rare, but they're there. And again, there's a double jeopardy because you bleed because you don't have enough levels of factor VIII, and you bleed because you don't have the platelet sticking property of this von Willebrand factor. And the next slide, the next slide shows the inheritance. How is this inherited? So almost always it is inherited, passed down from the mother or father to the child. And the gene is on chromosome 12. So all of us have 46 chromosomes, okay? 23 from mother and 23 from father. 22 of them are called autosomes. They take care of the rest of the body, your eye color, your hair color, your lips, your teeth, etc., etc. One set is the sex chromosome, X from the mother and Y from the father. So the von Willebrand disease is an autosomal disease. So it's not a sex chromosome disease like hemophilia is, but there are other genes which modify it. So if you look at that picture, it can be autosomal dominant. That means if you have the gene, you have the disease. And this is a person with only one von Willebrand disease chromosome has mild or moderate von Willebrand disease. But if you have two chromosomes, one from father and one from mother, then you can have severe one. In an autosomal recessive, that means that it's like a hidden gene, and the person with one von Willebrand gene does not have it. But if you have two of them, recessive ones, you can have severe von Willebrand's disease. It's a little difficult to understand, but it can be recessive or it can be dominant. The next slide, and there is I think there is a session on genetics. Please attend that to understand the genetics of von Willebrand's disease. So who is affected? And we can go to the next slide. What is incidence and prevalence of von Willebrand's disease? So the next slide will show that about 1% of the population, like 3.2 million or 1 in 100 are affected. And it occurs in men and women and boys and girls. Unfortunately, in women and girls, they bleed every month when they reach menarche with menstrual periods, or they can bleed with childbirth. And the next slide shows that where exactly, if you can show the next slide, the prevalence and incidence. So just want to tell you, prevalence means how many people have the disease. So all of you who are watching this session, how many of you have disease? If there are 100 of you, and 100 of you have the von Willebrand disease, then the prevalence is 100. But if incidence is newly diagnosed, if one of the 100 is a new person, then of course the incidence is 1 in 100. So the next slide shows, this was a study done by CDC. They looked at 24,200 cases, and they found the most common type was type 1, followed by type 2, and the rarest, as I said, mentioned before, type 3. And when you look at men and women, there were more cases amongst women than men. And whether it didn't matter, whether it was, mostly in type 1, you can see more women. New cases of type 1 von Willebrand's disease amongst women was 3 times higher than that amongst men. So what does it mean for you? So if you have sisters and grandmothers and aunts and things like who are bruising, bleeding, and all that, please think about von Willebrand's disease. The next slide shows a map of United States. The dark areas are where there are a lot more people with von Willebrand's disease than the light gray areas. This is just to show, all of you are from different areas in your part of the world. I think it's there in every part, but more in some parts. And the next slide shows, when you look at the age distribution, type 1, the orange is women and girls, the blue is men and boys, and the gray is everybody. And you can see in type 1, it's very common between the ages of 10 and 19. Whereas if you look at type 2, it's similar, a little bit low. They get diagnosed a little bit later. And type 3, it's equal amongst both men and boys and women and girls. In the next slide shows the clinical, we can go on to the next slide. So I'm kind of go over how do these patients present, as a child at birth to 2 years of age, and then older age group, and then adolescent and adult. So this was a study that we did with CDC, and if you have a family history of von Willebrand's disease, that's in the gray bar in that graph, you get diagnosed earlier at about 6 months of age. But if you don't have a family history of von Willebrand's disease, you tend to get diagnosed a little later at about 11.5 months. So what is the importance of this? Please find out if amongst your family members, if anybody has von Willebrand's or not, and bring that to the attention of your treatment team. Now, most of the children, 3 out of 4, had a bleed in their first 2 years of life. So we always hear about hemophilia bleeding early, but children with von Willebrand's can also bleed. And 60% bled before they turned 1 year old. And where did they bleed from? They had bleeding in the head. You remember, little children kind of walk around and bump into things, so they can get, bleeding in their mouth. They fall, they're getting their teeth out. And in boys, they can bleed with circumcision. So remember, it's very important to know that whether you have a family history or not. And head bleeds, although kind of uncommon compared to hemophilia, can occur with von Willebrand's disease. And it was interesting in this study that we found that mothers who had a family history of von Willebrand's disease were more, had more scheduled C-section than those without it. So it is important to check the body of your child during a shower to make sure there are not all these abnormal bruises and things like that. Or if you see a lot of bruising, bring it to the attention of your treatment team. The next slide shows what happens in a little bit older children, 2 years to 12 years of age. I'm not going to go into this in detail, but just to tell you, in the maroon bar are type 3. So these are children who bleed, are diagnosed very early, and they use treatment product. But the sad thing is, if you don't diagnose and treat them early, they end up having to use canes and crutches. They can bleed in their joints and all that. So be aware of it. How about boys versus girls? So boys can bleed at a younger age, but as girls start getting menstrual periods, they can report heavy menstrual bleeding. And minority children with Hispanic or Pacific Islander or Asian, unfortunately, sometimes it's very hard to detect bruises in these children, but they are at a high risk for bleeding, compared to children who are non-Hispanic white. So the next slide will show you adolescent, and you can see a picture of an adolescent girl with a bruise. And oftentimes they say, I don't know how I got this. And the other common thing, which I'm sure all of you are aware of, is nosebleeds. And these are nosebleeds that just doesn't come and go. They last for a long time and occurs with really no trauma or injury. And you can see bumps and lumps from all these bleeding larger than the size of a quarter. And the next slide, and this bruising and bleeding can persist into adulthood. And the next slide shows what happens when you age, when you are an older person with von Willebrand's disease. Well, the levels increase in especially type 1, but doesn't change in type 2 and 3. When the levels increase, it doesn't mean you bleed less. When you get old, you can get actually a lot of biopsies, breast biopsies, cervical biopsies, all kinds of things, and all kinds of surgeries, and you are at risk for bleeding. But at the same time, your aging makes you at risk for clotting and heart disease and things like that. And one of the things we are very interested in, perimenopausal bleeding. These are women who are attaining menopause and they can bleed. And one of the sites, a very irritating site, is bleeding in your gastrointestinal system, in your stomach and intestine. It's called gastrointestinal bleeding, or bleeding in the urine, or bleeding in the joints. A lot of people poo-poo the bleeding in the joint, saying that, you're just complaining. But no, it is a serious issue. You can bleed in your joint. And the next one, next slide, shows the gastrointestinal bleeding. It's a bunch of blood vessels seen on scope. So if you find blood in your poop, please be aware. There's nothing wrong. Just look at the toilet bowl, for heaven's sake. Sometimes you can save yourself a lot of issues with bleeding and being anemic and all that. And this is unfortunately a persistent issue. And some patients require prophylaxis with von Willebrand containing factor to reduce this kind of a bleeding. It can be pretty severe. And the next slide shows the joint bleeding episode, and occurs at all ages and most common in type 3. And what happens is you have difficulty in moving joint, your range of motion is decreased, unable to straighten, and I think the most important thing is pain. And if you have pain in your joints, difficulty in moving, think about a joint bleed, and please bring this to the attention of your treatment team or your physician, and don't listen to somebody who says it is nothing. Well, it is something. So, and you need to pay attention to it. The next slide about women. So women go through different phases of menstrual bleeding, bleeding with ovulation, that's in the middle of the menstrual cycle, and pregnancy. So bleeding can occur with von Willebrand's disease in all these. I don't want to overwhelm you with this chart, but just want to bring attention that women can bleed. And the next slide is now going to be taken over by Dr. Sean Job. So Dr. Job is a fantastic, he's a physician scientist. So most of us are physicians and we take care of patients, but Dr. Job is what I call a bench to trench guy. He takes care of all the molecular things and microscopic things on the bench, but then he goes to the trenches and takes care of the patient. So he has an MD, which is a real doctor, and a PhD, which is like a super doctor. And I'm so happy he is here at Michigan State University as our new director for the Center for Bleeding and Clotting Disorders. So Sean, take it away.
Oh, thank you, Dr. Kulkarni. My wife and family often say I just spend too much time in school. But I just love bleeding disorders. I love talking about von Willebrand factor and platelets. They're just fascinating and great to talk about and great to learn about from my patients and also at the lab bench. So I'm going to talk today about how I think about the diagnosis and give you an introduction to why your physician is asking you some of these questions about bleeding and what you can bring forward to your physician that might help them in thinking about what test order, why they're ordering different tests, and help you in having that conversation. So next slide, please. So this is just how a physician will look at this. And so when you come into the physician's office to be evaluated for a bleeding disorder, they're thinking about all of these different things and the possibilities. So I'm going to break this down for you over the next couple slides and talk to you about the importance of a history in making a diagnosis of a suspected bleeding disorder. So next slide, please. So what is a history? A history for a physician is listening. So we ask specific questions and we are looking for things that might guide us as to the next step in the diagnosis and in thinking about it. So there's elements of a history that are the personal history, there's a family history, and then we asked about medications and allergies and all those things. And so and it will help you to understand what von Willebrand disease is and what a platelet function disorder is. We haven't talked a lot about platelet function disorders, and we aren't going to today, but they're very similar in how they present. So I incorporate that. That's why this is an evaluation of a suspected bleeding disorder and not suspected von Willebrand disease, because we know that there's many different potential causes for a mild bleeding disorder, what we call a mild bleeding disorder. So in the personal history, you obtain that from the parent and the patient. What I find is very useful is having the mom and the daughter there, or the mom and the child there. And if the dad's there, great, but it's usually the mom. So, and then one thing that I find very helpful as well, don't be afraid to show the pictures on that you keep on your cell phone of bruises, especially. They can tell a story about what goes on. So if you sense that one child bruises more than another, it's a lot easier to show a picture of that to the physician than it is to describe 12 bruises on one leg, 5 bruises on another leg, or so forth and so on. So think about that as you come forward. The other part of the history that's important in obtaining a lifespan history is recognizing that diagnostic value is proportional to the number of hemostatic challenges. So what does that mean? The more a kid grows, the more opportunities they have to have a bleed. And what are those opportunities? And I view it as just a way to get a history. So these are developmental opportunities that happen. So they help the physician understand, your medical team understand what are the things that place you or your child at risk. So I think of the bleeding challenges as, first of all, you have exploratory trauma. So I love it when kids go out and explore the world. And so the bruises on their shins are a great hint to what's going on with them. They're not harmful to your child. They just are, but they tell you that your child is doing things, and if that child seems to get more bruises, maybe they have something that tells you that they might be helped by evaluation by a physician for other things moving forward. Nosebleeds are an important part of the history. So nosebleeds seem to occur primarily in kids between the ages of 4 and 10. And it's probably because their faces are changing. Think about your kids and how their faces change when they're growing up. And so they're getting sinuses, new blood vessels are growing. You'll hear from your pediatrician sometimes that this is due to nose picking. I would love to get that. I mean, yes, if you pick your nose, you will get a bloody nose, but I have children of my own. And I have yet to see them get a bloody nose with sticking the finger and exploring that far up their nose. So what I'm saying is don't allow yourself to be written off. If you sense there's a problem, keep on talking. And of course, menstrual bleeding, as many of you are aware. So menstrual bleeding is a normal physiologic thing. And so that physiologic bleeding that occurs can be excessive in the setting of von Willebrand disease or platelet disease. Finally, there's different challenges that the medical system provides that will allow you to assess what's going on. So the immunizations, when a child is immunized, sometimes you'll have a large intramuscular bruise, or surgeries, that the nature of the surgery will tell you about what's going on. I put blankscopies because often we are asked about guidelines about laparoscopic endoscopies, whatever a physician might be doing to look to see if something's going on. And don't forget about dental procedures. So dental procedures are also important to think about. Next slide. The family history I find to be especially informative in regard to an inherited bleeding disorder. And some things that I find asked are helpful. So in young women who are concerned about the possibility of excessive menstrual bleeding, I really go out of my way to ask mom about what their experience was during high school. In inherited, you often learn about your periods from your family members, if you're a woman. And you don't talk about it, from what I've heard. You don't talk about it outside of that. So it's not uncommon for somebody to not think that they have a problem when other people looking into that would say, well, that is excessive. Some things that give a hint as to whether mom had a problem is, did she have to have a surgery to have her uterus removed because the bleeding was just so excessive? It's not that uncommon to elicit that history. The other things that I ask about is, did you plan your life around your periods in high school? And I always ask about high school because in America, that's a regimented time period. So 1 hour, 1 hour, 1 hour. And a mom is not, it does not seem to forget what she experienced, and she does not want her daughter to experience that as well. And so asking that history beyond just quantifying, you can't necessarily quantify at the age of 35 what happened to you 10, 20 years before, but you can remember how that changed your life and how that impacted your life. So that family history obtained by asking slightly different questions can be very useful. And also just asking about whether there's any things inherited disorders might be linked to bleeding. Next slide. And finally, medication. So ibuprofen use, of course, as many of you have been told. So ibuprofen use, if you have a lot of ibuprofen being used around a fever, sometimes we can find out, well, it's just because of ibuprofen. So your doctor will ask about those things. Might get some blood tests to look at other things as well. Next. Next slide. So there are tools that are available to help your pediatrician or your family practice doc to think about whether or not you might need referral to a specialist for evaluation. I strongly encourage people who think they might have a bleeding disorder, people who think they bleed differently, to seek evaluation by a hematologist, somebody who thinks about bleeding disorders, and not necessarily rely on these tools. But these tools can be helpful if you think you're on the borderline, you're not sure what to do with that. So, and this is the International Society on Thrombosis and Hemostasis, together with the NHF and ASH, came together to make these guidelines about what these were useful for. And you'll hear about these guidelines from Angela Wyan moving forward. But basically what this says is that the ISTH bleeding assessment tool is good for a screen, but it's not something that your physician is going to rely on to say you do or do not have a bleeding disorder. Next slide, please. So one of the tools that you can use to look at it is available on the NHF website. So it's called Better You Know. And so Nicole's going to talk to you a little bit more about it at the end. Next slide. So these screening tools ask things that specific for an individual about menstrual periods. So bleeding for more than 7 days from the time bleeding begins until it completely stops. Gushing of blood that limits daily activities. So do you have are there things that you do that are different than other people have to do for bleeding around their periods? So using double protection. Women have sometimes come up with ingenious ways to live their lives to their fullest. And so just asking those questions and bringing those things to your physician and letting them know what's going on. Next slide. So laboratory testing is useful for your physician in determining what type of a bleeding disorder you may have. It does not make the diagnosis of a bleeding disorder on its own. So you can have low von Willebrand factor levels. Now this is me talking, but you may not have bleeding. So in some ranges 30 to 50, we know there are many people out there that don't seem to have bleeding. But for some people, level of 35 to 50 is a bleeding disorder. So in the absence of, the important thing here is though, that in the absence of a history, laboratory testing alone cannot rule out a bleeding disorder. So there are things that your hematologist does not know, that even though they've studied extensively, they know there's so much that we have to learn about the fascinating process of hemostasis. There's disorders out there that are inherited that we are still identifying. So keep working with your physicians to think about that. Laboratory testing can infer a high risk of bleeding. So you can say with von Willebrand disease that individuals with bleeding symptoms are bleeding symptoms are more likely in those less than 50, and we need to look at it. So that's where the guidelines came from for less than 50. So if a laboratory abnormality cannot be identified, so it's important to think about in von Willebrand disease, if let's say you're being evaluated for von Willebrand disease, that it could be a disorders of platelets that are causing it. And I just want to add that your doctor may get something called a PFA. That is not the end all and be all of platelet testing. So make sure you think about platelet evaluation moving forward. Next slide. So in the management of VWD, as you work together with your doctor and treatment team to figure out what works best for you, these are some tips that I can pass on. So determination of your von Willebrand disease type may be helpful. It might guide to either DDAVP, desmopressin, or it might guide towards replacement with von Willebrand factor. So what is desmopressin? So Desmopressin is a natural stimulant of von Willebrand factor release from endothelium. So it mimics a part of the stress response to cause your own body's stores of von Willebrand factor to be released into circulation. So if you have type 1 von Willebrand disease, that's a great tool because you're releasing more of a functional protein out into the system, and it's actually active and ready to go. It's right by the blood vessel. So often DDAVP is not only adequate, it's the better therapy because you can raise levels to something with a more natural type of product. Now, it does have some side effects. So it has flushing that your doctor would talk to you about that can limit the utility of stimming. And then it may not have a response in some people. So that's why your doctor will ask you to do a DDAVP challenge to make sure that you're not one of those 5% of individuals that might not have a response that is adequate in an emergency situation or other things. So while type may be helpful, a desmopressin challenge and laboratory assessment of DDAVP response will be helpful in determining what would be best. Don't forget that long-term prophylaxis using von Willebrand factor replacement is available if you have recurrent or persistent bleeding issues. If you have nosebleeds that are not able to be controlled over a period of time and you keep on trying and you keep on having nosebleeds, or if you have a recurrent GI bleed with angiodysplasia or joint bleeding, long-term prophylaxis may be helpful. And don't forget about menstruation with menstrual cycles as well. I personally love the use of antifibrinolytics. I find they're very helpful, especially with the introduction of Lisdeta or tranexamic acid. It does not cause nausea. It doesn't have those big pills like Amicar does. The tranexamic acid is especially useful, I think, when you want to prevent the next nosebleed or you want to decrease the amount of blood flow with a period. And then don't forget to talk to your HTC about what's going on. So let them know about if there's a dental procedure coming up. Ask them, do I need to do something with the cleaning? They'll probably say no, but go ahead and ask. Maybe you always have problems with the dental cleaning. Go ahead and give them a phone call if you're concerned about, are my daughter's periods too long? Or is my sister's? These are my sisters. So don't be afraid to ask those questions. That's what your hemophilia treatment center is there for. And as people age, they get aches and pains. So nobody seems to forget that they can't take ibuprofen. But what you can take if you have a bleeding disorder is you can take medications that have an ibuprofen-like effect that limit inflammation that will help with those chronic aches and pains. So Celebrex, Mobic, bring those up to your doctor to see if that makes sense for you, because you can use those without blocking platelet function. Next slide. So these are your choices. I've talked about for management of VWD. I've talked about all of them. Just a few. Desmopressin, that's available intranasally, hopefully, again, in the future. Right now, many of you have probably been told by your doctors, if you are aware of it, that we are limited in our ability to have the use of the intranasal formulation. That's the spray that's used in the nose to cause a DDAVP release everywhere. You can still give DDAVP IV, that's available. Some places are giving it subcutaneously, so that's an option as we wait for this stimate to come back. Factor replacement is very useful in emergency situations and for those people that don't have an adequate DDAVP response, or those who are unable to do that. If you have type 2 or type 3, you may not make enough of a functional von Willebrand factor for DDAVP to be useful. And finally, I mentioned the antifibrinolytics that are available. Next. Moving forward, there's ways that people are thinking about this that I just keep on boggling me. So gene therapy, people have heard about. That's probably going to be a little bit down the road. I mean, there's limits with gene therapy about the size of the von Willebrand factor, where to get it, constructions, and so forth. How do you make that? Gene editing, that might be very useful. If we figure out how to do that specifically where von Willebrand factor is made, that might allow us to specifically target a defect and get at it. We can prevent it. We can use monoclonal antibodies. There's ways to think about using non-von Willebrand factor dependent products to in those individuals with type 3 von Willebrand disease or 2N, to think about how we could raise the factor 8 level independent of von Willebrand factor. So moving forward, the future is bright. I'll work together with your hemophilia treatment center. Your physicians there will guide you towards what's available. We'll tell you about the research that is up and coming and give you some insights moving forward. So I'm look forward to taking any questions, and thanks for the opportunity to speak.
Thank you so much, Dr. Job, and also Dr. Kulkarni for that lovely, lovely presentation. That was a lot to take in, but I feel like you were able to simplify it so we can understand, because I think it's sometimes some of this stuff is at a very high level. Perfect. I was just going to ask Dr. Kulkarni to turn her camera on as well. Fabulous. And for those of you who are watching, if you want to see all three of us at once, in the right top corner of your computer, you can select gallery view, and that way you can see us all. Oh, actually, that makes it worse. Maybe just stay on speaker view. I take it back. But nonetheless, we're going to go ahead and transition into the Q&A part of this session. And thank you again, Dr. Job and Dr. Kulkarni. And I'm taking a look for questions, and I'm going to just go ahead and start off with one that I have. And this one is for Dr. Job. So Dr. Job, you talked about the levels for VWD and the cutoff. So there's been discussion of a VWD like cutoff at 30, but can you explain why you chose 30?
So 30 was picked by a panel of experts based on knowing that that's where you are able to identify a genetic cause for that low level of von Willebrand factor. And so that's why the number 30 was picked. Now, the number 50 is kind of a realization that people between levels 30 and 50 have a higher risk of bleeding, even though they might not have a clear genetic reason within their von Willebrand factor gene for that. And so we know that individuals with levels less than 50, that they have a greater risk of having particularly heavy menstrual bleeding, bruising, nosebleeds, the things I talked about. So there's now a category within the new guidelines that say between 30 and 50, you need to take bleeding symptoms into consideration and a family history of bleeding into consideration.
Thank you for that.
If it's less than 30, you are automatically labeled as being needed assistance of your treatment center and guiding you forward with a potential hemostatic challenges.
Thank you, Dr. Job.
It also, it helps the insurance companies, you know, I used to have so many patients who would bleed, but the levels were not 30 and below. But my God, you know, if you have von Willebrand, you're not a level, you're a human being who's bleeding. So there you go, you come first.
Woo, I'm giving that a big clap. Thank you, Dr. Kulkarni. Thanks for throwing that in there. And I will leave it up to either of you, but can you just talk to us a little bit more about what is the deal with stymate? Like what should we know? Do we need to know anything? Did you say everything we should know? But what's the deal?
So Stimate has faced a manufacturing challenge. So your hemophilia treatment center has gotten in touch with you. I'm sure about the Stimate and what has gone on with it. It's not that it was a dangerous product. It's that it was a product that you need to have a controlled amount that's delivered. And so as the company figures out how to overcome those manufacturing barriers, we've been kind of handcuffed in what we can do. We are looking forward to this becoming available again. And there are numerous groups that are trying to figure out how they can make a temporary replacement. But in the meantime, you just work together with your hemophilia treatment center to talk about the options that are available as we all eagerly await. And I know that Len and NHF is really working to get but it's just a matter of moving that forward. It's just going to take time. So.
You know, the nicest thing about Stimate was puff, puff in your nose. And, you know, for children, you didn't have to poke them. I mean, you have the sub-Q available and you have the IV available, but it means poking a child. And in many cases, even adults who are big, you know, you cannot find a vein or they don't like, nobody likes pokes, including me. So I just wish that we would get along and again, have Stimate available. And the way I explain to patients is when you squeeze it in your nose, one in a nostril or one in each nostril. What it does, as Sean said, was it releases the von Willebrand factor from your blood vessel wall. So it's like toothpaste. Okay, this von Willebrand factor just comes out like a toothpaste. And so why would you want to poke yourself for a toothpaste?
That's fair enough. Fair enough. Well, I think we have time for, I think maybe probably 2 more questions, but I think I'm going to pose this one to Dr. Joe for now. But I'm just going to give you an example. Like, say a young patient, they fell and they hit their head, right? And they need to go to the emergency room. What steps, and say they're young, they need their parents. What steps should their parents like take? Should they just go straight to the ER? Like, this is an example, right? Should they call you first? But like, how would you go about a situation like that? Is it better to like let the ER know in advance and you, or not? But tell us a little bit about like what.
So if you observe the fall, then make sure, if you don't observe the fall, the first thing that you should do is, and you find that your child has fallen, take them to the emergency room, give a call on the way if you can. Don't let the phone call get in the way of you needing to evaluate. So take them to the emergency room. Hopefully you've worked together with your hemophilia treatment center, develop an emergency treatment plan about what should be administered for that. I think having that emergency treatment plan is very important. And then if you have factor available, bring that with you, because that will be very helpful, and hopefully they'll administer it. The other thing is that keep on advocating for your child. Keep on saying, but my HTC told me that they should get the factor before they go to the CT. There's no such thing as wasted factor or wasted product in the setting of a child that may have intracranial hemorrhage. I never view it as a waste. That is not something that, so you just do it and then you ask the questions.
Thank you, Dr.
I just want to add to that the importance of having a medic alert. You can have a bracelet, anklet, necklace, earrings. There you go. So what happens is then people are not, if you're unconscious, let's say, I mean, this happens with hemophilia also, and nobody knows, they waste a tremendous amount of time trying to find out why are you bleeding. And you can save a whole lot of time by just knowing or helping the physician know that this is what you have, and they will know how to treat it or who to call. And please, the bracelet or those things should be on your body, not in a bag or not in a friend's house.
You heard it from Dr. Kulkarni. Don't keep it in your bag, everyone. Well, Dr. Kulkarni, Dr. Job, I wish I could keep asking you questions, but we really are coming to the end of our short time together. So with that, I would love if my lovely tech person could go ahead and put up our final awesome thank you slide, so you can all see that slide. But thank you again, Dr. Job. Thank you again, Dr. Kulkarni. I appreciate all your time and efforts that you put into this session, all of the emails, all of the PowerPoints. So it was a lot of work. So everybody at home is definitely giving you like that virtual round of applause. But I want to thank again all of you at home for joining us